will be available on the WhatsApp group for people to watch the video, and I think it's going to be posted on YouTube as well. For people to access this. Then what I was planning to do is I was planning to have a short presentation because the topic for today is psychotherapy. We'll be due to finish at 12 o'clock. Please feel free to interrupt, to speak, to ask questions, to comment on what I'm saying. So that's absolutely fine because I do want this session to be as interactive as possible. Righty then. So what I'll do is I'll share my screen. I'll give a kind of a general overview of psychotherapy stations, and then I've also prepared 3 stations at the end. So really glad if people would want to volunteer. I'm happy to act as the in the scenario, and I can give you feedback as well. And it's a really good opportunity to practice. Essentially, it's not about getting it right or getting it wrong. It's about learning, and we can all learn from each other. So that's my thought in terms of how to do this, organize this session. All right. Anything else before I make a start from anyone? Okay. Do interrupt if anything comes up. But in the meantime, I'll share my screen. Let's see. Okay. So let's see if I can make this. Right. Can people see my screen? Just shout out if you can. Or maybe I will exit the presentation because okay, because I couldn't see the Teams screen. Let's see. I'm just gonna keep it like this. Okay. Right. Okay. So I'll make a start then. So as I said, this is going to be about psychotherapy stations for the CASC exam. I'll give a brief overview of the exam, not dwell too much on it, but just as a helpful reminder. The last set of exams took place in Sheffield in person, so they're no longer on Zoom because, well, remotely. So this session in January will be in person as well. It's split up into an AM session and PM session. AM session will have 8 stations. Both sessions will have 8 stations. Be mindful you get 4 minutes reading time for the morning stations. That's usually because there's more material to read. The cases are a bit longer. So that's where you have a bit more reading time, but also a bit more thinking time. So you're never gonna need 4 minutes to read the case, but it's a helpful time to have because you'll get a notepad and a pen to jot down some notes as well, kind of gather your thoughts, think what is it that I'd want to ask in this question, in this clinical scenario. So that's where your management stations are going to fall into the AM stations, AM session, because they're usually longer, and use the time in terms of management to kind of have a bit of a plan in your mind of how you want to run the station, and you get 1 history and 1 examination station as well. So that's like physical examination. And then you have the PM session. You have again 8 stations, but this time it's a shorter amount of time. You only have 90 seconds as reading time, and it's split into 4 history stations and 4 examination stations. So you're kind of doing risk assessments or mental state examination. So that's a quick overview. Now, if we are to look at psychotherapy stations, I suppose it's a bit hard to give a very specific list of things that you should do or shouldn't do in psychotherapy stations because they are quite broad. and they're quite different. It depends on what station you get. So I'm going to go through some common stations as well, but very general tips, and not just for psychotherapy really, but for all CASC stations. Be polite, be empathetic, be respectful. Especially for psychotherapy, be as curious as you can. We don't know what's happening. You want to understand. You really want to understand where the patient is coming from. You really want to understand their position, what they're experiencing, what their difficulties are. And it's also about kind of the idea of emotional intelligence, and be attuned to what the patient brings in. So for example, if you feel that the patient, you say something, and the patient kind of looks away or pulls away, or makes a bit of a kind of a frown, or feels a bit angry or irritated, you can pick it up and say, I see that when I'm speaking to you right now, you're looking away, and I can see that you're struggling. Do you want to tell me about what's happening for you right now? Or you get into a session and the patient's really angry. I think the best thing to do in this situation is to actually label it and say, I can validate it essentially. I can see you're very angry at this point. And that's really, really helpful. And then you can kind of have your own way of managing that. But what I tend to do is I tend to kind of sit down, maintain my calm, and my be quite composed and confident, but validate the patient's feelings, and try to kind of de-escalate the situation. So kind of say, I can see that you're quite upset at this moment in time. Why don't we use the time that we have to see how I can help you, or if we can do anything about it, or something along those lines. So it's about having developing your own skills, and your own way, and also how you practice in day-to-day practice. But yeah, it's important. Don't ignore verbal cues. Um, Provide empathy. So always kind of validate, mark the emotion, or provide validation and empathy, and say, it needs to be said. It needs to be said for the examiner to kind of pick it up and say, yes, the candidate has been empathetic. So, something even along the lines of saying, it must be really hard for you going through this right now, or it sounds very difficult what you're saying. Um, yeah, something along those lines. And then be mindful of your communication skills. I'm not going to go through it, but active listening, checking understanding, pausing, chunking information, try to see where the patient is coming from, what are the kind of ideas, expectations, what are their concerns. So yeah, I'll move on to the next slide. One big thing is, make sure you read the station and make sure you do what the task is asking you to do, because you will get psychotherapy stations which will say, explain CBT. Make sure you do that. Or you will get stations, assess suitability for psychotherapy. Make sure you do that. Or you don't go off and do something else, do a risk assessment, or do a mental state exam, or talk about something completely different, or a different type of therapy. Really make sure you focus on the task. For me, what I found really helpful in the exam is, in the reading time that I get, to just write the task down to make sure I don't forget it. And make sure you have the time to address the patient's concerns. Pause from time to time and ask, is there anything, what is it that you'd want to talk about? What are some of your concerns? What are some of your questions? Pause from time to time, because that gives also the simulated patient a chance to give you more information and kind of guide you a bit. If you feel a bit lost, not quite sure where to go, pause and ask and see what the patient gives you. Because you're there to address their concerns ultimately, especially if it is a management station. My advice is, at the end, if you have time, summarize in the last minute. This is really, really important, because it kind of gives you, it gives both you and the patient and the examiner a quick summary of what has happened in the whole station. So this is what we've talked about, this is what we've achieved, and this is the plan. I know it's easier said than done, but when you do hear the 1 minute mark, make sure you don't open, you know, a big topic or change the topic completely. Ask about important things that you haven't asked. Quick things like, you know, drugs, alcohol, that's fine, but try to summarize in the time that you have left. And be mindful. I know you practice a lot of stations with your colleagues. You do a lot of reading, a lot of preparation. Expect differences in the exams. You might actually have the exact same scenario that you've read in different books or that you've practiced with your colleagues. Don't be surprised, or don't be don't be surprised if the station is different, or there are different bits to it, or something changed. That's absolutely fine. So don't worry about that. Just go with it, and be open-minded, I suppose. That's what I'm trying to say. Okay, now I'll pause here, and well, I mean, do interrupt me to turn on your camera, or don't, but unmute yourself, and let me know if you have any questions. I'll pause a bit to see if people have any comments. No, but do feel free to interrupt, please. Yeah, Ahmed?
No comments
No,
at all.
okay.
I think the scope is well covered.
Okay, good. Okay, now more general tips for psychotherapy stations. We'll go through some common stations, but ultimately, make sure you have a way in your mind to explain different stations. So, for example, if it's CBT, make sure you have a quick summary of how is it that you're explaining CBT. How is it that you're explaining, I don't know, cognitive errors? How is it that you explain systematic desensitization? How is it that you explain psychodynamic psychotherapy, or CAT, or whatever it is, interpersonal therapy? Just have a way in your mind that kind of makes sense to you, and it's simple, and it's quick, because it's hard to then to go into the exam and not be quite sure how to explain CBT and how CBT works. So have that in your mind. Ultimately, you will generally get one psychotherapy station in the exam. So it's not a massive yield of stations from psychotherapy, but you will get one. That is for sure. I got, for example, when I did my exam, I got one psychotherapy station, and I also got a patient with BPD and eliciting symptoms of BPD. I suppose in a way you could say I kind of got two, but make sure you practice, and you have a way of explaining, because it can be quite difficult to explain how psychotherapy works. You can get the leaflets from the Royal College. Mind has quite easy accessible information for patients, where you can read about different types of therapies as well. But the Royal College has quite a few leaflets. Make sure you kind of know what are indications for therapy. So what are some if people can shout out some indications for therapy?
Depression.
Yeah. So I suppose it depends on the diagnosis, right? And what is it that you want to achieve? But rather, so you're right, absolutely. And make sure you know, for example, depression, what's kind of the first line treatment for depression, what types of therapies are indicated for depression, or for anxiety, or for agoraphobia. What are the therapies which are indicated for psychosis, and so on and so forth. So make sure you know that bit. But it's also about, the patient needs to be in a position. You need to have a certain degree of insight to gain something from therapy. You need to kind of know that, okay, it is about working towards doing something different and making changes in one's life, in your own personal life. So you need to have a certain degree of motivation to change, and understand that. And in terms of contraindications, don't forget things like, for example, for depression. Well, if you're severely depressed and actively suicidal, therapy is not going to be indicated. You might need to be admitted, for example. Or if you're actively suicidal, acting on your thoughts with quite serious self-harm and things like that, active, so a sense of you're not stable at the moment to have therapy, then other interventions might be more appropriate than going for CBT, for example. Because therapy is not going to be enough to contain, in essence, if you're in crisis, you're not gonna make use of therapy. You're not gonna have the space of mind to make use of therapy. Also, if you're dependent on drugs and alcohol, that's a contraindication for therapy as well. Again, because you're not gonna have the space of mind to be able to make use of therapy and make changes in your life. If the therapy binges on drugs and alcohol, I wouldn't say that's a contraindication, but it's something to kind of hold in mind. But dependencies are, if you are dependent to drugs and alcohol, and talk about make sure you talk about the psychotherapy, how the therapy is structured, how CBT is structured, how many sessions, how long is the time for this session? What's the format of the session and of the therapy itself? What is it expected of the patient to do in therapy? Because it's different, for example, from CBT than from psychodynamic psychotherapy. Make sure you tell the patients that there is also a lot of work that happens outside the sessions, in between the sessions, such as homework, especially if it's CBT. And don't forget, yeah, I know I mentioned this, but I'll say it again. Don't forget to check for motivation. What is it that you want to change? Ask the patient, what is it that you want to work on? What is it that, is this something, for example, if it's agoraphobia or whatever depression, is this something that you want to work on, that you want to address, you want to change? Right. So if we go through the most common psychotherapy stations in the CASC exam, essentially the first one, or kind of the classic one, is CBT, generally CBT for depression. And it is about being able to explain that. You're probably going to get a patient with a history of depression, mild to moderate, has tried medications or hasn't. It doesn't quite matter. It is about talking to them about CBT, and it is about explaining what CBT is. And then again, go back to your definition or your way of explaining. I tend to kind of think of it in a way of, well, you have your cognitions, you have your thoughts, you have your behaviors, and you have your feelings, and explain to the patient how they interact. So, for example, by changing or addressing our thoughts, our negative thoughts, and you try to use the example in the scenario. So if the patient tells you, oh, I feel very low, and then I'm very critical of myself, and I think I'm good for nothing, and then I cut myself off and isolate myself. Well, that's the thought, right? I'm good for nothing. The feeling is, how does that affect your feeling? Well, that makes you feel low in mood. And how does that affect your behavior? Well, you cut yourself off. Essentially, you isolate yourself. So, for example, the way CBT works, and it's really good to use the examples that the patients give you in the scenario by changing behaviors. So having a gradual kind of putting in place gradual activities, then you can change the way you feel about yourself, and you can change some of the thoughts, or you can address some of the thoughts and challenge some of the negative thoughts that you're having, and see how that then affects your feelings and your behaviors. So yeah, that's kind of CBT for depression in a nutshell. I'll pause a bit to see if someone has any questions or thoughts. Amina? No? Okay, no, okay. And then cognitive errors, that's another station. It's not a very common station, to be honest with you, but it can come up. It is about, you have the classic case in which you get a footballer who missed the goal and his team lost, and it is about kind of minimizing all the successes he's had in the past, magnifying or overly focusing on this one failure, this one missed goal, kind of generalizing that, saying that, you know, I'm a bad husband, I'm a bad father, not only a bad footballer, but I'm bad at everything. You know, catastrophizing or black and white thinking. So it is about kind of exploring all of that with the patient, and literally just labeling them and eliciting them, but also make sure the examiner knows that you've picked them up. And you kind of explain them to the patient. Then quite a common station is one with agoraphobia or OCD. You know, ultimately, agoraphobia, hold in mind that agoraphobia is graded exposure. So essentially, you make a hierarchy of anxiety-provoking activities, because ultimately it is about trying to get out, and ideally trying to get out on your own without using safety behaviors like going with someone else. And it is, for example, with that, it would be the first step is to get close to the front door and touch the doorknob. That would be the least anxiety provoking. And you can couple that with relaxation techniques and work yourself with the help of the therapist, work towards, you know, eventually going out on your own. So that's graded exposure in a nutshell. Don't forget the relaxation techniques. And for OCD is exposure. So it's similar because you're exposing yourself to anxiety-provoking situations, but it's more about response prevention. So not engaging in the rituals. So for example, touching I don't know, touching a doorknob and not and inhibiting the behavior of washing your hands compulsively. And Yeah, so trying not to, because the compulsions are essentially safety behaviors, and trying to sit with the anxiety and also use relaxation techniques as well, for example, to work through the anxiety. And also for OCD, it's kind of challenging some of the thoughts that one might have in OCD, and also in agoraphobia as well, because frequently people with agoraphobia might think that they're going to die, or that something horrendous is going to happen. And same thing with OCD as well. So it's about challenging those thoughts. Other stations or common stations are, for example, in interpersonal therapy. This is usually the kind of classic case of someone with depression, has tried CBT in the past, maybe, or has tried medication in the past, and it is about kind of trying to identify changes in one's life. So, for example, I think in the case, if I remember it correctly, it is about a lady who's, you know, lost her job, lost her mother. So there are changes in one's role, there are changes in one's relationships as well. Which then contribute to the depression that the person is having. Another one would be termination of therapy and transference reaction. This can be a tricky station if you're not quite sure how to attend to it, or how to manage it. It's one of the practice stations that I have. So perhaps I won't go in too much detail about it. But essentially, it's the classic case if someone comes to your clinic and says, look, I'm not going to therapy anymore because it's useless. The therapist doesn't care, doesn't listen to me. They're critical of me. And it is about having an open mind and exploring that. Okay, well, that's really important. That sounds really challenging. What's making you say that? What happened there? And then the key is to then link that, the sense of feeling not listened to, feeling ignored, feeling criticized. I wonder if there are times this sounds really important what you're talking about, and I wonder if there have been times in your past, in your life, when you felt in quite a similar way in which you're feeling at the moment with your therapist. And see what they say. You know, they might say, you know, I feel the same way with my wife, or I've felt the same way with my father as a child, or whatever it may be, and kind of making links. And again, have a way of explaining transference, because if you've never tried to explain it, it can be quite challenging. but essentially it is explaining it as in, you know, our past relationships and the way we felt in our past relationships and the way we experience past relationships can color how we are experiencing relationships in the present time. Right? Then the other one is defense mechanisms. This is more psychodynamic defense mechanisms. I think generally you might get the case of a patient coming to your clinic and talking about some quite important changes in one's life, and then but actually the trouble is they're in denial about the changes at home, within their relationship, and the problem is, well, they're not getting along with coworkers and they're getting very angry at home. Sorry, in the work environment. So it is kind of picking up what are some of the defense mechanisms that are happening here, such as, for example, denial, projection, you know, reaction formation, or whatever it may be, trying to kind of elicit those. Right. Another kind of I would put it in the psychotherapy stations, to be honest. It is borderline personality disorder, and it is, you generally get a patient either in clinic or in A&E, with you know, it essentially says illicit symptoms of borderline personality disorder, and it is about eliciting the symptoms, and that's what it is. It can be challenging because you need to be empathetic. You really need to be empathetic, because the more empathetic you are, the more the patient is going to give you information, and it's not easy to elicit things like unstable sense of self, impulsivity. So you need to kind of make sure you have a way in which you ask those questions to manage to elicit the symptoms. Or, you know, how do you elicit splitting? How do you ask for splitting? You know, so for example, I asked the patients, well, do you sometimes feel that you know, you've done something or an interaction or something's really great, it's amazing, and then you know, the next minute or whatever, it feels horrible or really bad or useless. Same thing with kind of emotional dysregulation, try to pick up changes in the mood, suicidality or suicidal behavior, reckless behavior. So make sure you know the criteria first, and then you have a way to ask for it and to elicit the symptoms in a way which is very sensitive as well. And the trick here is, patient might be in A&E, they might have taken an overdose, so you'll also have a clinical background and a clinical scenario to it that you need to kind of attend to and weave that into the symptoms, because that's the presentation. You know, they'll say, I've taken an overdose. So it is about asking that. So they're probably going to tell you, I've taken an overdose because I got into a round with my partner. Okay, so that's unstable relationships, isn't it? But make sure you ask, how are your past relationships? How have your past relationships been? Pick up fear of abandonment, for example. Pick up emotional dysregulation. So you need to weave it in with the clinical scenario, because you can't just be tick box. You know, do you feel empty? Do you sometimes feel angry, and so on and so forth. Yeah, so I think if you practice it, it becomes a lot easier, because the key to all of this is to be able to do it in 7 minutes, and it takes practice. Okay. And the other one is CAT, cognitive analytic therapy. It's not a very common station, to be honest, but just make sure you know what CAT is and how it works. Same thing, you might get a station with DBT, explaining DBT to a patient. Know what DBT is, and you know, can you summarize DBT in a minute, in terms of explaining it, and know what it is for. What are the indications of DBT? Well, it is about addressing self-harm and BPD. That's what DBT is for. But make sure you know how it works. You have individual sessions, you have group sessions, the duration of it, the coaching within DBT, Same for CAC, make sure you know how it works about the mapping, the tools that you have. You know, the therapist is gonna write a letter to you, then you're gonna do a map and look at the patterns, relational patterns that you get into. Again, CAC is a relational type of therapy. The therapist will write a letter at the end. So yeah, that's about it in terms of stations. So I've prepared. Sorry, new stations. There are some new stations for the CASC exam, which is one is CBT for psychosis, and the other one is family therapy for psychosis. They're tough stations if you've never done them before, or if you don't know what CBT for psychosis is, it's impossible to pass it. Or if you're not quite sure what family therapy is and how it can be used in psychosis, it's impossible to pass the station. So make sure you have a read of those and kind of have the basic knowledge. You don't need to be an expert in it by all means, but you need to have an idea of it. So before we get on to the stations, because I prepared three stations. We might not be able to do three, but maybe two. I'll pause to see if people have any questions.
Just a quick one, Dr. Island, if you don't mind.
Yeah, of course.
I hope
Yeah.
I pronounced it very well.
Yeah.
So for that cognitive distortions one, do you identify the distortions as you go along, or will you just want to wait at the end? What are your thoughts?
I first come in with an open mind and try to first get an understanding of what's been happening. And as you see them coming in, do point them out to the patient. And, you know, you'd say, so, okay, so I see, you know, you might be catastrophizing here, that, or it might feel, but don't just use the word. Make sure you also explain what it means, you know, so don't use the word splitting without saying what it means. You could say it feels like I'm getting a sense in which it feels like all the successes you've had until now, they kind of mean nothing at the moment for you. You're just purely focusing on this one thing, or the one failure that you've had. So you know you're magnifying. So use the word, you know, you're magnifying on this one failure. Or it sounds like you're overgeneralizing this one failure, because what you're saying to me is it sounds like not only you feel that you failed as a footballer, but you've also failed as a father and as a parent, sorry, as a husband. So try to weave it in, if that makes sense. Yeah. Okay. Any other thoughts or comments or questions? I suppose with that, try not to be too prescriptive and too rigid. Have a tick box in your mind, but don't be too fixated on it. Allow yourself to be open and see what comes and what the patient gives you. But have a tick box on the background in your mind to then think, okay, what else do I need to talk about? What else do I need to address to kind of not lose track of the station? But be as open as possible. Any other questions?
Thank you.
Okay, no, you're very welcome. That was a very good question. Thanks for asking. Okay, so I have a clinical scenario, which is to do with psychosis, CBT for psychosis. Would someone want to give it a try?
I can try if you want me to.
If you want to, yeah, absolutely.
Thank you.
So just for the sake of time, is it all right if I give you 60 seconds?
Yeah, that's
and
perfect,
then
please.
and then I'll play it. Is that all right? And then
Yeah, that's fine. That's fine.
Oh,
Okay. So I'll do the timing so
Okay.
that you don't have to, yeah.
Oh, that's very helpful. Thank you, Ahmed.
Okay. So doctor, do you want to start reading now?
Yes, thanks. I've started.
Right. 3, 2, 1. Please start.
Hello, is it Sam?
Yes.
My
Yes.
name
Hi
is
there.
Dr. Collins. I'm one of the doctors in the department. I
Mm.
understand I'm supposed to discuss some difficulties you've been having and see if you'll be suitable for a kind of therapy we call CBT. Is that your
Oh,
understanding
okay.
as to what this review
Yeah.
is?
Yeah. Thank you. Thank you for speaking to me, Dr. Collins.
Perhaps what might be helpful is just to have an idea of what has been going on. Can you hear me?
Yes. Yes.
I understand from your note that you had this diagnosis of first episode psychosis.
Mm.
That was 6 months ago. How was it for you?
Yeah, it actually started, well, I think it started 8 months ago. And, I was just really, really paranoid. I was thinking, I just started university. I started studying chemistry and I moved into the student dorms, and I was just for 2 months, I was really thinking people were talking about me and kind of gossiping about me, and I could hear it as well. They would say nasty things about me. But it's been okay. I mean, I got help, and I started risperidone, and ever since I don't, I'm not like paranoid anymore. Hear voices.
And just to get this clarity, you said it started about 8 months ago. Did you think you're entering university at that time and the work at the university probably made things worse for you? What was your take about it?
Yeah, I think it was a really stressful time because I had to go to a different city and move away from home, from my family, and that was quite tough and quite stressful.
I'm actually happy, Sam, that you actually got the help you said you
Mm,
had. But during
mm.
that period, how were you able to cope at all, you think?
It was hard. It was hard. I ended up going back home, as my parents noticed that something's not right with me. I wouldn't attend my courses. I was too scared to attend my courses, and I was thinking people were after me. So yeah, and well, I mean, I started smoking cannabis as well. Um, yeah.
And how much do you smoke, if you don't mind me asking?
I still smoke cannabis. Maybe I smoke cannabis once a week. It just helps me relax, you see.
And just to check with you as well, Sam, I know you were given this diagnosis of first episode psychosis. Was that something that made sense to you at the time?
It didn't at the time. It didn't at the time, but at the moment it does. It does make sense. I can see that I was quite paranoid and I was hearing voices, and medication has helped. Um, although I'm not sure if I want to continue with the medication, to be honest, but yeah.
There any particular reason why you don't want to continue with it?
Just I don't know. I feel fine, at the moment. I feel fine. So not sure if I really need it anymore. It has helped, but don't yeah, it's not something I decided upon, but it's something I'm thinking about.
And that's what might be helpful is for me to take it down memory lane, if you don't mind. I know it's
Mm.
not meant to be an easy question, but when your mom was pregnant for you, did she say there were any difficulties you had at all?
No, 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 none. No difficulties whatsoever.
Just to check with you, when she gave birth to you, did she say you cried immediately after birth, or were there any problems at all during delivery?
No, 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 no. No problems that I know of. None whatsoever.
That's good to know. And I know you did speak about your family there. And just to check,
Mm.
is there anyone in your family that has any mental health diagnosis at all or anything?
Oh, actually, no. You asked about this. Yeah, it was my grandmother on my mom's side. She had schizophrenia. Yeah, yeah.
How was she? Was she well taken care of at all?
Well, she was in and out of hospital, to be honest. She passed away before I was born.
All right. It must have really been a difficult experience for the family then.
Yeah.
But just to check with you at the moment, I know you've spoken about lots of difficulties. Sometimes you say you do cope with cannabis as well.
Mm.
How are things for you at the moment in general, you think?
At the moment, I think they're okay. I do want to go back. I'm still at home. I do want to go back to studying. I do want to go back to university. Um, it's just, you know, things are going well. Things are going well. But I do want to be independent, and I don't want to rely too much on my parents, because I just don't want to burden them. You see, I don't want to be a burden to my parents.
And that's really positive. And once again, thanks for being open to me. But this is also a question we ask everyone as well. I know you said you want to go back to university, but do you feel you have any thoughts to harm yourself at the moment at all, you think?
No, 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 no,
About any
no,
thoughts
no,
to end your life
no,
at
no,
all?
no, no.
Okay. So you've given me lots of useful informations, really. And I know you said you really want to go back to university, but at the moment, are you in any relationship at all?
No, no, I'm not. No.
So certain things that I've actually noticed, because part of what I'm supposed to discuss with you is just to make sense of what has really been going on. And from the discussion, you did tell me there was no concerns when your mom was pregnant for you. But again, there was this difficulties with the diagnosis your grandma had about schizophrenia, which I think probably would have likely predisposed you to having this because of the genes and genetic factor as well. But again, all these are on the background of you going back to university, you know, the stress with university work and things like that. And that made you started developing the symptoms you were having. You spoke about hearing voices and saying things that are not there. And because of this stress, you started using something like cannabis just to help you cope. But the good thing is that you are looking forward to going back to university, which is a positive. You don't have any thoughts to harm yourself or end your life. So these are things that we think, but the fact at the moment is that you kind of, your diagnosis makes sense, but you don't know if medications will be helpful. And I think having something called CBT would help make you understand that better.
How would that
think?
help? How would that help?
So it will actually help, because most times the way we think could affect how we feel and then how we behave. So at the moment, you think medication is not helpful. So just helping you tease that out and see how that can help you, we think would be a good way to go, really.
Right.
What are your thoughts about it?
Yeah, yeah, it's something that sounds interesting.
I will offer you a leaflet about it, really, and just help explain things more to you. And
Thank you.
happy if you come back and talk to me as well.
Thank you. Thank you very much. So I think we're at time now. Well done.
Yeah, thank you.
Well done. How do you think you've done?
I think it's just more like trying to not sound checklisty, really, and just trying to make sure and make it a conversation and a two-way thing. It's not really easy, especially when you have a structure you really want to maintain. But for me, it's more like not really using the 5 Ps and saying predisposing because of that, precipitating and things like that. If you know what I mean.
Yeah. No, yeah, I think you've done really well. You're empathetic as well. You're curious. You've tried to structure the information. You've summarized it at the end. Don't forget to speak about CBT and how CBT works and what CBT, you know, and how CBT is going to be helpful here, because ultimately it is about medication. Medication is one thing, but it's also about stressors and how to manage stressors, because stresses can precipitate a psychotic episode as well. So, you know, for example, I said that I fear burdening my parents. So another avenue could have been like, oh, okay, so how is it that you manage then with your difficulties and problems? And I would have said something along the lines, well, I tend to keep them to myself, really, because I worry about burdening people. I just try to solve my own problems. And then what happens? And I get overwhelmed. And that's another stressor as well. So it is about how is it that I manage stressors, for example. It's about relapse prevention. What are some of the things that can prevent me from having another relapse? Cannabis is one of them, medication is one of them, stressors is one of them, and also trying to be able to identify when I'm having a relapse and what to do in that case. And don't forget to have that triad of connections of thoughts, feelings, and behavior. But yeah, well done. Let's see what else. So this is the station. It is about and well done also on kind of eliciting what happened and the symptoms as well. So it is about getting it's about getting the formulation, predisposing, precipitating, perpetuating, and protective factors as well. And on top of that, explaining what CBT is and how it works for psychosis. So it's not an easy station by all means, especially if you're not quite sure what is it that you need to cover in it. So we have 10 minutes left.
Thank you so much.
No, you're very welcome. Any final questions about this before we go on to the next station? No. Okay. It might feel like I'm rushing things, but I thought since we have, well, 9 minutes now, we can fit another station in. What do you think, Ahmed? If you're around or you're on mute, I can't hear you. But we'll just carry on doing another station. Let me just can you still see the screen sharing? I think you can, yeah. Okay. So do we have another volunteer for a different station? And the next station will be transference reaction. Well, discontinuation of therapy.
We have a volunteer for the station.
Don't worry about, even if you've never done it before, it's absolutely fine. It's not about getting it right or getting it wrong, but it would be a really good experience.
Okay, if nobody is happy to do it, let me try it then.
Oh, thank you very much, Betty. Thank you for volunteering. Okay, can you see my screen share?
Yeah.
Okay, good. Ahmed, do you want to help me with the time?
Yeah, yeah.
Perfect.
Dr. Betty, your time starts now.
Okay.
Please start, Dr. Betty.
Hello, Mr. Brown.
Hello.
My name is Betty. I'm one of the mental health doctors in the team today.
Hi, Betty.
Hello, Mr. Brown. I understand we're here to discuss some concerns about the therapy you go to. Is that right?
Yeah. I don't want to go to therapy anymore. This is not helping. This is not helping at all. You know, I went to a psychiatrist and I was struggling with my mood and I was depressed. And they said, well, they started me on an antidepressant and they said, well, therapy might be helpful for you as well. So I started therapy, but this is not for me. I'm not going back there. This is making me worse. It's a waste of my time, really.
Yeah, Mr. Brown, I can see you really, you look quite upset and distressed about wanting to stop.
Yeah. It's quite frustrating. Yeah.
I can see that as well. And is it okay if we could talk a little bit more about this situation and see how best we can support you through this?
I guess so. I didn't really want to, but I thought, what's the point? But yeah, I guess we can speak a bit about it.
Yeah. So there are many reasons why some people would want to discontinue therapy. I'm just wondering if there's been any change in your circumstances, Mr. Brown.
No, there hasn't been any change. No.
You haven't moved address or
No.
no? Okay. And then could it be problem? Could it be something that has to do with the therapist himself or herself?
Well, actually, you know, the therapist is cold. really, really cold, uncaring. He's critical. I just feel like he just doesn't care. And it's just making me worse.
Right. That sounds quite serious. Could
Yeah.
you tell me your therapist, please?
Sorry?
Could you tell me the name of your therapist?
I think it's John. I think it's John.
Oh, all right. So you say John sounds quite cold.
Yeah.
Oh, right. Could
Well,
it be?
he just sits there, you know, he just sits there and doesn't just sits and he's you know, yeah, I'm not finding this helpful. He just doesn't care. He just sits there and listens.
And listens. Okay, and could it be that he's incompetent? Do you think he is? Is incompetent in?
I don't know. It's just I don't know. I don't know if he's competent or incompetent. I don't feel like he cares really.
Doesn't care. But have you noticed him being unprofessional to you in any way?
No, I don't think so. I don't think so. I don't think so.
Right. So, Mr. Brown, you've said some few things about your therapist, and this just make me wonder if you've experienced anything like this before.
What do you mean before?
Like maybe if anyone close to you now or in the past have acted like your therapist?
Ah, I see. I mean, now I suppose now that I think about it, my dad was really cold and really not interested. And he used to spend most of his time at work, and he was barely ever at home. And I just felt when I was growing up, I felt like he never really cares about me. But I just don't understand what this has to do with my therapist. You know, he doesn't care. My therapist doesn't care. So I don't want to go back there. And I just don't understand why this is relevant.
Mr. Brown, what you've said about your dad sounds like you really had a difficult situation growing up. Okay, but from what you've said to me, it sounds like there seem to be some similarities in the way your therapist acts and the way you're as well. This makes
Okay.
me wonder if there's something called a transference reaction taking place between you
What
and
is
your.
that? What is that?
So it's actually a term we use in the type of therapy you go to, where there's a very strong emotional attitude that that gets transferred from a previous relationship, as in your case, your dad,
Okay.
gets
Okay.
transferred onto current relationships. Now,
Okay.
okay. And what happens is that, unfortunately, this tends to mirror your future relationships.
Right. Right.
So it's actually something to explore during therapy session, Mr. Brown.
So do you think I should go back to therapy?
Well, actually, I think that is the best decision at the moment because, Mr. Brown, if you are able to explore this situation further with your therapist, it will help you understand what happened between yourself and your dad, and that would help you build better, stronger relationships in future.
Right. I see. I see what you mean. Okay.
Yeah.
Okay.
And you said you've had you've attended 3 sessions, isn't it?
Yeah.
It would be important if you could to continue attending more sessions, so to explore more about what has actually caused this depression, and we'll support you better through this.
Right.
Okay.
Okay. I see.
And I hope I've not overwhelmed you with a lot of information, Mr.
No, that it's I suppose it's been I'll have a think
One
about
more
it.
minute. One more minute.
I haven't decided fully, but I'll think about it. But is this something you can speak to my therapist about? I don't know if I really want to go and speak to him.
Yeah, Mr. Brown, I can see this sounds like it could be quite difficult, but it's something that you have to do with your therapist. Both of you to explore this together, and I'm sure your therapist will support you through this. Okay?
Okay.
I'll give you a leaflet just to read about this term we call transference reaction in therapy. Thank you for speaking to me today.
Thank you. Let's leave it at this. That's
That's
great.
good. You had 16 more seconds. You had finished and then you dropped it, but you had 16 more seconds, which is great.
No, it's great. Thank you so much. And thank you for volunteering. Well done, Betty. Specifically in terms of feedback, I think it's hard to give detailed feedback because we don't have a lot of time, but I think you've done really well. You've done really, really well. One thing that I would say to it is also ask, never forget to ask the patient, have you spoken about those difficulties in therapy with your therapist? Because that's quite important. Because I would have said no, I just sat there and I didn't feel like this could be talked about or understood. And it is about encouraging the patient to then go back and well done on not kind of taking the responsibility and saying yes, I'll speak to your therapist. Because it is the patient's responsibility. Okay, well, thank you for that. We're at 12 o'clock, 12:01, so we're a bit late. One last thing I wanted to say kind of as a final mention is, let me share my screen. If you do wish to book one-to-one sessions with ourselves, sorry, window, let me get the window up. PowerPoint presentation, yeah. You can contact us, or you can go on our website, acecasc.co.uk. We're also offering an online Teams mock CASC exam, which is scheduled to take place on the 6th of January. So do sign up ahead of time if that's something you wish to do. But as we said, we do have one-to-one tutoring sessions that we provide as well. It's 4 tutors, 4 of us. Yeah, I'll just leave that on the screen as sharing. But any final thoughts or questions or comments? I hope it's been helpful, because I know psychotherapy, it's not something that is extremely easy, but hopefully it's not something that hopefully doesn't feel impossible, because it's not. But it does take a bit of practice. Yeah.
Thank you so much.
You're very welcome. You're very
Thank
welcome.
you.
And thank you for all of you for attending today, and thank you as well for those volunteering and for being brave. But hopefully it's been a good experience and a useful experience for everyone.
Yeah.
Thank you, Dr. Ilian, and thank you, Mrs. or Mr. Liu, for keeping the time. Thank you.
That's great. That's great. Right. Should we end it at this?
All right, that's all right. Thank you very much.
Thank you all thank you for coming. Take care. Goodbye, and be in touch if you're interested in one-to-ones or the CASC mock exam. Take care. Goodbye.